All right. So, folks might be asking, where's the place for psychotropic medications in the DICE approach? And there definitely is. And often we'll think about using psychotropic medications first line if there's imminent risk, and that can include major depression with suicidal ideation, psychosis that is causing harm or potential harm to others or the person, as well as aggression with risk to self or others. Currently, there are no FDA-approved pharmacotherapy for dementia-related behaviors. However, many classes of medications are used off-label in real-world settings. The most common medication classes that are used to address behavioral and psychological symptoms of dementia include antipsychotics, cholinesterase inhibitors and memantine, antidepressants, mood stabilizers, and benzodiazepines. And when we think about how to best target medications to the behavioral disturbances that are occurring, we generally think about this symptom-clustered approach, meaning for symptoms of, say, psychosis or agitation or aggression, generally we'll think about using an antipsychotic medication. For patients who are experiencing depression, we'll think about using antidepressant medications. For patients who are experiencing disinhibition, significant mood fluctuations, thinking about using mood stabilizers. Unfortunately, this approach is not necessarily evidence-based, but it's our best way to try to best match the problematic behavior with the medication class that's most likely to help. It's important to remember that there are certain behaviors where psychotropic medications rarely help. So, for instance, unfriendliness, poor self-care, memory problems, inattention, repetitive verbalizations, and wandering. These don't tend to be great medication targets. And as we've mentioned before, other than sedating someone, there sometimes is not a great way to stop someone from asking a question. And so really trying to think about which symptoms are going to best respond to medications. Medications can be used as a temporizing measure for harmful behaviors while working up and treating the underlying causes. For instance, for a patient who has significant aggression, psychosis in the setting of a urinary tract infections, antipsychotics could be used for a time-limited fashion for sedation and treatment of psychosis. It's important, though, to remember that patients with premorbid psychiatric diagnoses like bipolar disorder and schizophrenia can still develop dementia. And for these patients, we don't recommend taking them off of these medications once they develop dementia, especially if they're still exhibiting symptoms of their underlying psychotic disorder or mood disorder. We recommend continuation, especially if it's improving patient quality of life as well as patient safety. Barring that folks are on medications that can cause additional problems in dementia, like highly anticholinergic medications, often we'll keep people on similar treatment regimens and try to lower the dose if we can. So some key points. So there's currently no U.S. FDA-approved pharmacotherapy for dementia-related behaviors, and medication choice is generally targeted to the symptom cluster that's most problematic. So for instance, use of antipsychotics for treatments of agitation or psychosis, use of anticonvulsants or mood stabilizers for treating disinhibition, antidepressants for treatment of depression. Certain behaviors such as inattention, repetitive verbalizations, and wandering are not generally great targets for pharmacotherapy, and behavioral interventions should be prioritized.